floor is yours, Dr. Budiano.
Thank you, Pak Yudi. Bismillahirrahmanirrahim. Assalamualaikum warahmatullahi wabarakatuh. Thank you very much for this opportunity. Dear David Ciblok, PhD from Erasmus Medical Center, right, Rotterdam, the Netherlands, and also head of study program of Doctoral of Public Health, Universitas Diponegoro, Professor Dr. Sendra Filudin, and Pak Yudi Darmawan, PhD, Secretary of Study Program of Doctor of Public Health, Universitas Diponegoro, and also our colleagues, lecturers, and all of the participants, especially students of the doctoral program. Thank you very much. I think this topic is very important for us because this topic can apply to many fields, especially in public health. So data modeling is, I think, process that can create something like visual representation data, one of them, I think. And I think the goal of this data modeling is to visualize, analyze, and also define data type. And the most important is to analyze relationship between the data itself. And the goal of this data modeling uh, can support the decision making based on the data that we gather before or we collect from any source or some sources. And also this process creates something like a blueprint for the database, which can help organize data efficiently and also ensure the integrity and facilitate better decision making, like I mentioned before. And data modeling, I think, also plays an important role in public health by enabling, for example, the prediction of disease outbreak and assessment of the transmission dynamic, and important too for evaluating of intervention strategies, especially in health program, I think. And Indonesia as a tropical country, we have so many infectious diseases with infectious disease problem, and I think in Indonesia is so many infectious diseases like dengue, hemorrhagic fever, malaria, filariasis, and so on, and also tuberculosis that Indonesia ranked to in global. I think it's data modeling also have some benefits, can help us to understand complex data set, I think, and also how they relate to each other, and also give the foundation for creating database, platform, and also software or application that align with the health program needs, and can guarantee too for ensuring quality and consistency of the data itself, and then facilitated better decision making and support for the information technology, something like that, especially for infectious disease. In this case, is for the leprosy disease, right? And also has opportunity for the facilitating collaboration with the sector, I think. And we will get more comprehensive explanation of what data modeling is and how is it applied to infectious disease analysis and also control, and what steps should we take and what consideration are needed to implement it. I think David from Erasmus Medical Center, Rotterdam, the Netherlands, uh, will explain about the role of data modeling in infectious disease control. And I think this lecture is very important for all of us. And I hope you all pay attention and more active in discussing. And finally, enjoy this lecture and success for you. Thank you very much. Assalamualaikum warahmatullahi wabarakatuh.
Thank you so much, Dr. Budiana, as our dean speech is very wonderful and also inspired us. And I hope David can share with us about his expertise in data modeling. And I know him well because so many articles has been published by David in about the data modeling. Thank you, our dean, Dr. Budiano, for your opening speech. And so we can continue to the main event in this event. Before I let David to give his presentation, maybe I want to share about David CV. So I'll let to share. Okay, I hope everyone can see our screen. Okay, so yes, David Block is an academic researcher in public health and a senior infectious disease modeler at the Department of Public Health of RSMC, University Medical Center Rotterdam, the Netherlands. David holds a PhD degree in public health and master degree in epidemiology, health economic, and economic. So David has so many research focused on the neglected infectious disease with a focus on developing and evaluating intervention strategies using mathematical model and also epidemiological or economic approach. David also member of the NTD modeling consortium since 2015 and has been active in developing mathematical model for several entities, including leprosy and also onchocerciasis. Now David work focus on leprosy, and David also involved in project assessing the feasibility of risk elimination, evaluating the potential impact of single dose rifampicin as post-exposure prophylaxis, and also in diagnosis. David also as a facilitator of the Global Partnership for Zero Leprosy Research Agenda, working on epidemiologic modeling and socioeconomic research, and also the chair of GPSL's country modeling working group and member of the leprosy working group. David also member of the WHO TEG for leprosy since October 2022. So you can see so many publication has been published by David and also his team, and I know well some name in this publication because I also include in this department since 2020, and David is one of modeling team in Department of Public Health in the Rotterdam in the RSMC, and so many paper has been published by David and his team. So I think that is the short introduction of David, and now I will stop my share and we can continue to the main event to learn about the how to build and maybe develop data modeling. And David, if you're ready, the floor is yours.
Thank you so much for this nice introduction. Let me first share my slides. Can you still hear me?
I didn't see anything in our screen, David.
Yeah,
Maybe
yeah. I think
must
it
wait
fro
for
it
me.
it it froze my screen.
Ah,
I'm not sure whether I'm now. No, I'm not sharing the right
okay.
screen.
I can see now, but maybe
Yeah, but it's the
mm,
wrong screen. Yeah. One moment. I'm trying to do this again.
maybe you can try again to share. Yes, okay. I can see now.
Yeah.
But maybe you
No.
can make it as a screen
Yeah.
so bigger.
Try.
Yeah.
Yeah.
Okay, thank you, David. Please go ahead.
Yes. Great. So again, thank you so much for this invitation and this very nice introduction. So the topic for today is indeed the role of data modeling in infectious disease control. And since my experience is primarily in leprosy, I'm gonna provide a lot of examples in the field of leprosy, and hopefully to help you understand the importance of modeling for infectious disease control. So just to manage the expectations, I'm not going to tell you about how you should do this, but the main topic for today is um, to teach you about the importance of modeling and how modeling can support policy decision making and support informing strategies, but also inform supporting research. And I'm providing a lot of examples, but I'm not gonna go in detail of how you should do that, but more a big overview in what way modeling can support public health policy making. So let me start off. What is data? So the title, it says data modeling. Data modeling is a very broad concept, and my expertise is mainly in mathematical modeling, as you may know. Our research team at Erasmus has a very strong expertise in that field, and today I'm gonna talk primarily about that, about the role of mathematical modeling for supporting public health policies. But first of all, you might not all be aware of what models are. In general, we can say that models are a simplification of a real life situation. So you observe something in real life, for example, an epidemic, and you want to study that epidemic. How to study that? Of course, you can only study that by getting data about that epidemic, and to some extent simplify the real life situation to get an understanding what is going on. And that is exactly what models are, a simplification of a real life situation. It will never be perfect. That is the big disclaimer, but it comes close to, and it helps us to understand what is going on and what we need to do to stop it when it's about, for example, an epidemic. So in general, in health, models are used to, in the first place, we're not going to talk about it, choices in healthcare. So for example, should we choose treatment A over treatment B? So this is more in a clinical setting. Secondly, to investigate research dynamics in patients and populations. And thirdly, to support public health decision making. So our focus for today will be mainly on the last one, but also a little bit on the second purpose of models. And again, models are complementary and no substitute for data and trials. So again, models are a simplification of real life situation, and we need to continue collecting new data. We need to continue doing trials to improve those models, because with new data, with better insights, with better understanding of what is going on, through, for example, trials, we can improve those models, and we can come one step closer to real life situations. So our conclusions that we derive from those models are more in line with real life situations. And again, also, it is important to keep continuing collecting data and doing trials, because also time may change systems. So an epidemic 30 years ago would be different than an epidemic that we face in these days, because there are new factors playing a role in this era of time. So I want to focus on mathematical modeling because this is my main expertise. And I want to give you some reasons why we think, or I think, that mathematical models are needed in complement to statistical models. And the most important reasons, especially when we're talking about infectious diseases, is because infectious diseases behave in a nonlinear way. What this means is you cannot predict how an epidemic spread. It's not linear. It's not like, okay, if we see one case, then this case will lead to, in a linear way, to so many cases in 2 or 3 years. No, it's non-linear because it depends pretty much on behavior. If you think, for example, on COVID, you can see that COVID was sometimes unevenly distributed. It really depends on your contact pattern. How often do you come in contact with big groups? Do you take public transport, or do you gather together much? So people that gather together with other people are more at risk than people that are staying at home all the time. So it's non-linear. You cannot say like, okay, for everyone it's the same. So there are a lot of different factors playing a role there. And secondly, epidemics or infectious diseases require a population or a community perspective to understand their dynamics. So again, what I just said, the risk of an individual of acquiring a disease depends on, in the first place, the state, the infectious state of the population. So in the first place, how many people in your population, for example, has leprosy, which is of course determined by past history of an individual exposure. How did they acquire the infection of M. leprae, and when did they develop leprosy? And because you need to take into account the history of this individual exposure, but also the infectious state of the population, then only you can think of, okay, to what extent can we predict how this disease would spread in a population? And again, also, secondly, prevention also reduces the risk of infection to the remainder of the population. So there are actually two forces in place here. First of all, the risk is very much dependent on how many people are infectious. And on the other hand, we also treat people that are found with the disease. And this again reduces the risk of infection though. So there are two forces going on at the population level, at a public health from a public health perspective. And to what extent one force is stronger than the other force is sometimes difficult to understand. And that's also why we use mathematical modeling. So what is it actually? Well, mathematical models are quantitative descriptions of epidemiological mechanisms and processes. So it is used to explain data. It is useful to combine multiple data into coherent frameworks. So whereas statistical models probably use one data set at a time, mathematical models can combine different data sets and use them in a coherent framework. And so far, when we talk about leprosy, it's the only way we have of predicting future leprosy trends and effectiveness of future programs. But also, we also need to consider that there are gaps in knowledge and mechanisms and processes. And because of these gaps, basic processes like transmission are not always fully understood and also not fully described, because we have limited knowledge about this, limited data about this. And how can we go around that problem is usually to address it by varying assumptions. So if you don't know what is causing transmission or how strong. For example, if you don't know whether asymptomatic cases are infectious, we can test it in various assumptions. A case in where, for example, asymptomatic cases are not infectious, and a case where, for example, asymptomatic cases are assumed to be infectious. And again, to highlight it, models are complementary to what we observe, the data, and also what we learn from trials. So when we think about transmission of an infectious disease, there are many, many factors that play around. Usually during my lectures, we do this kind of like interactively, but since this is an online meeting, just showing some examples. You can think probably of many more examples. But first of all, you can think of human behavior. When we think of COVID, it really depends on your contact pattern, also the population density. We see that it really depends whether you live in a rural area or a urban area where the population is more dense, and certain infectious diseases, for example, that are highly infectious are more dangerous in high dense areas because there's a lot more chance that you come in contact with someone who might be infected. It also depends on to what extent are you susceptible. Some people has built to some extent some kind of immunity to certain infectious diseases because we don't exactly know who is immune and who is still susceptible. This is really a big factor that actually determines transmission. Also, the infectiousness. Some diseases are highly infectious. Treatment availability. Do we have a treatment? If we have a treatment, then we can counter the effects of transmission. The environment itself, especially when you think of vectors. If you think of vector-borne diseases, I think in the introduction mentioned malaria, dengue. They are all vector-borne diseases because carried by a mosquito. Also the living conditions, we also see in some poor living conditions, it's easier for certain diseases to spread than perhaps in other conditions. And there are probably many, many more factors that you can think of, but this is just like an example of what kind of factors you should take into account when building models. So again, I'm reiterating myself a little bit, but now I'm gonna go a little bit more into specifics. Like there are different types of models. So we are not focusing on patient models. Patient models is mainly to think about, for example, which treatment should you provide to a patient, treatment A or treatment B. But we are focusing on population models because we are looking this through a lens from as a public health researcher or scientist or official. And population-based models are interested in what the effect is of, for example, an epidemic on the population. Can we expect this epidemic to grow? And to what extent do we grow it? Does it grow? But also at the same time, how can we prevent it if we have certain measures? For example, if we have a vaccine, to what extent will it go down? If we have other measures, to what extent it will go down? And there are generally two types of population models in the space of mathematical modeling, where we use different types of data in a coherent framework. And this is the compartmental models. Compartmental models really treat groups of population at the same time. So they make assumption that populations are homogeneous. And with agent-based models or individual-based models, these are models that follows individuals over time. And this is also the focus of our talk for today. So when we talk about population models, especially compartmental models, we can think of dividing a population into different compartments. And how many compartments there are depends usually on the disease, on the infectious disease. But you can imagine in the simplest form that we have a population, let's say, of a certain island in Indonesia, and a large part of that population is not sick, it's just susceptible. Um, a small fraction is sick, that's the I that is infectious, and some people are already recovered of the disease, so they are based in the R. And basically, if you understand that, okay, so many people are in compartment S, susceptible, so many people are in compartment I, infectious, and so many people are already in compartment R, and over time they can be again susceptible again for the disease. So it's kind of a circle. And if you then also understand from the data what the transmission rate is, then you can kind of calculate how this epidemic will develop over time. Because the more infectious people you have, the more people that flow from S to I. And if the recovery rate is not high enough, they remain in I. So you need to make sure that there are enough preventive measures for the gamma. So it looks like a Y, but it's actually a gamma that goes from I to R. And if you make sure that enough will go from I to R, then you can suppress the epidemic in a population. So the more sophisticated way of doing this is doing the same, but not for groups of people, but for every individual. So, and why do we use this? Because sometimes you're interested in the life course of individuals in a dynamic population, because every individual is unique and has unique characteristics. So, for example, some people in the population may have better conditions, and therefore this protect them from a certain disease, while other people don't have those better conditions. In generally, these models are stochastic. So there are many events in the model, transmission events. They usually are determined by chance. And because it's stochastic, we allow it to be stochastic, because sometimes, like in real life, by chance, someone miraculously recover, or someone sometimes the epidemic explodes, and sometimes it fades out without any cause. So it takes into account this kind of like stochasticity in a model. And it's called agent-based because individuals are seen as agents and can interact with each other. So on the next slide, so models, we're talking now about simulation models. They generally have three components. They have demographic processes that might determine the course of an epidemic, birth and death, perhaps also household processes, movements, people moving out of areas, people moving in of areas. We have like a population that consists of, like in reality, people living in households together, and we have, on the other hand, disease and transmission processes. It's now more complicated because we explicitly here on the right-hand side also included, this is an example of leprosy, by the way, leprosy control, how different aspects of, for example, the natural history of infection, how different aspects will affect the natural history of infection, treatment, for example, but also how transmission is very much related to how the population, like we said before, population densities, for example, very important. The structure of the population is very important. If you have very big households, you can imagine that diseases may cluster in those big households. So these are all factors that are playing a role in such big models. And you can also imagine from this picture is that we use different sources of data to combine them in a coherent framework. We use data about the population density, about household sizes, for example. You use data, demographic processes, a lot of people moving in and moving out a certain area. And we also use data about disease and transmission processes. So for the data, the models need data to be quantified. And as I said before, I think what makes mathematical modeling a powerful tool is because it is in principle able to combine different types of data in a coherent framework. And that is data on, for example, demographic processes like birth and death rates, age structure that in certain diseases may play a huge role because certain diseases may be more prevalent in certain age groups, for example, children, or others more in older age groups. Data on disease. We have epidemiologic data over time. We have data about the natural history of the disease. So within a person, if you get infected, what happens? What are the stages someone goes through? And we have like understanding about historical and current control. So when the treatment started, how is the coverage of those treatment? How's the compliance of treatment? Do people comply with treatment or not? Because that also determines how well your program is working. If you provide treatment to a patient, but the patient will not take the treatment or will stop after 1 day, then also the effect will be lost, although they might be registered as being under treatment. So it's really, you need to be really careful about these type of factors, and you need to get a good understanding about, okay, to what extent when we read that for example, 90% of patients are under treatment, whether they are really under treatment and to what extent they comply with the treatment. So what we try to do with models, we try to replicate again what I said at the very first slide, real world processes, and in such a way that we are able to mimic what we see in the real data. And this is an example again of leprosy, where we try to mimic what happened in India. We see here a large peak in India that we can explain because there was a surgence of active case finding activities, which led to this huge increase in the number of cases. And afterwards, there was a big drop, partly because you find a lot of cases, but also partly because they were, for some time, they thought the disease was gone, so they stopped looking for it, and we see a huge drop there. But what I'm trying to show here on this picture is what we try to do is modeling, is we want to try to get an understanding what are the processes that are going on and underlying these trends of certain diseases. And with the data we have and with the model that we have, can we mimic and can we replicate real world processes? And if so, how can we use that in our advantage? First of all, we can say like, okay, we can predict future trends to see, okay, for example, here, we know we had data until 2023, and what does the model predict if nothing else happened? And can we see that it goes to 0, or does it kind of stabilizes over time? So I think the remainder of this talk, I want to focus on what can model tell us. So now I gave a kind of a brief overview of different types of models and what these models can do and how you could use these models. But now I want to talk about what can model tell us. And in principle, there are 3, and especially for public health practice. especially or there are generally like three main themes that model can teach us, or models can teach us. And first of all, it can assess the performance of current practice. Basically, it can make prediction of the near future, to see like, okay, if we assume that what we're doing now to this date will continue for say the next 5 years, or let's say the next 10 years, what will happen? Do we see the disease coming down? Do we see it coming back, going up? Do we see it stabilize? And I think that is usually the first important way of using these models, to understand, okay, what we've done so far, how good is it for our future? And secondly, is also to evaluate impact of either existing or also new intervention, to see like, okay, the models can tell us, okay, let's say current practice is not enough. Let's say we have a new intervention and we have data from trials from that new intervention, and we combine the data from trials from that new intervention to the coherent framework that we have developed, and see like, okay, to what extent do these interventions impact the trend. And thirdly, we can also use models to determine specifications for tools and programs. For example, if you are developing a new diagnostic tool for a certain disease, for example, in leprosy, diagnostics are still in development, and we can use models to tell us, okay, what should be the sensitivity of the tool, what should be the specificity of this tool to be effective in the field. Because sometimes in certain conditions, a lower sensitivity is already good enough to have an added value. On other conditions, you really need a high sensitivity. So the remainder of this talk, I'm gonna provide you some examples from the field of leprosy, the field I've worked in. I've covered all these three topics and even more, and I'm trying to give you an understanding of how these models can be helpful to do policy making. And I think it's really, models are really strong in that sense, because it has been recognized, I think, by many governments, by the WHO, for example, as a powerful tool to at least inform strategies, to inform policies, to see, okay, what should we do now? Is it good enough what we're doing now, or do we need to do something else? And that is what I hope to show in the next part of the presentation. So first of all, the next part of the presentation, all my examples will be about leprosy. I'm not sure whether everyone knows about the disease leprosy. I just have a few slides just to get everyone on the same page. Well, leprosy, my work was mainly in the field of neglected tropical diseases, and these are caused by a variety of pathogens, viruses, bacteria, parasites, and in general have a devastating effect on the health, social and economic consequences, and it's mainly prevalent among impoverished communities in tropical areas. And these areas usually have very limited resources. Here on the right, you see a full list of all those NTDs. And today I'm going to talk about leprosy. I have also experience in working on onco, a little bit on LF, but mainly on leprosy so far. So I'm going to talk a little bit more about that disease. Very briefly, what is leprosy? It is caused by Mycobacterium leprae, and it is a disease that affects, and the bacteria affects the skin and the peripheral nerves. And if left on treatment, people will progress and develop clinical signs and symptoms. And only when they have developed clinical signs and symptoms, they can be diagnosed. So there is no diagnostic tool yet that could detect patients that are still asymptomatic. It is important that we find those cases early enough, because with delayed diagnosis can lead to physical disabilities. And the WHO has, or there are like two grades. We have two categories of grade 0 is no disability. Grade 1 is there's anesthesia present but no visible deformity or damage. And grade 2 is the most severe form of physical disability, because you have visible deformity and damage is also present. And if you look at the global new leprosy case detection, what we do see here is that in the last decade, so we came from 4. In 1991, there was a resolution in the WHA taken that for elimination of leprosy as a public health problem. This, in the end, was reached in 2000 at the global level in 2000, and in most national levels in 2005. But there was this huge misinterpretation that elimination as a public health problem means that the disease it literally gone. That was not the case, and because of this, a lot of funds stopped in leprosy programs, and because of that, we do see that there's a lot of leprosy still going on. Many of these communities where leprosy is still prevalent. What we also see is in the last 2 decades, we see a very the number of cases has been fairly stable over time. So we do see that there is renewed effort needed to really substantially reduce the number of leprosy cases globally, but also at country levels. What we also see here, this dip, is because of COVID, because back then, during the COVID period, people were not looking, people were not diagnosed because of the lack of either the lack of health staff to diagnose, but also the lack of people going to health facilities for being diagnosed with leprosy. We see a big drop there, which has now more or less been recovered. What we also, so this is the same picture basically from 2005, but as an incidence rate per million. And what I also put in here is the child rate. The child rate is very important in the field of leprosy because it's a kind of an indication that transmission is still ongoing. So if the number of child cases is still above 0, we understand that transmission is very much still recent, because as a child, transmission can only be a few years back. So, one slide about the risk of leprosy. What we know from research, from studies, it is that those closest to an index patient, so have the highest risk of acquiring the infection and develop leprosy over time. So contacts of leprosy cases have the highest risk. And on the graph on the right-hand side, we see that household contacts have the highest risk because they live very closely to the index patients. Secondly, our neighbor contacts, also again depending on the setting, of course, but generally neighbor contacts are more commonly in contact with the patient than, for example, the general population. And finally, also social contacts. The social contacts you might not see on a daily basis, while neighbor contacts you still might see on a daily basis because you're just living close to each other. And you can see that the risk of the general population is the lowest, and that is usually the case. But there's one disclaimer to make. However, only 20% of all cases can be linked to known contacts. So what I'm trying to say here, when we study the patient and we study their contacts, we know that those contacts are at higher risk, but still a lot of cases are outside this context. So there are kind of pockets of small clusters of leprosy patients. So this is more recently, and I wanted to highlight this because this is often a framework nowadays that we keep in the back of our mind when we talk about elimination. So recently the WHO, with a big group of researchers, developed this elimination framework. I was also part of the working group for developing this framework. And we have now kind of for leprosy, this framework is for leprosy. We have developed this framework to guide national authorities, but also subnational authorities in their way to fight against leprosy. So what we acknowledge is like all the efforts that have been made to reach elimination as a public health problem. But reaching elimination as a public health problem is not enough to interrupt transmission, to stop transmission. And that's why we have developed all these 3 phases. So phase one means you have to have reached elimination as a public health problem. And now your next goal is to focus on the interruption of transmission. And we have defined interruption of transmission as having no new autochthonous cases among children for at least 5 consecutive years. As I said before, children is an indication of recent transmission. So if we don't have those for 5 years, this is an indication that we've kind of reached interruption of transmission. And then you entered phase 2, and then phase 2 is focusing on having reached elimination of disease. So this means that no one would have the disease in the population. This is defined as at least 3 consecutive years of no new cases at all. Plus, of course, in addition to phase 1. And afterwards, if you've reached that phase, you can enter the post-elimination surveillance, where sometimes you still might have some sporadic cases, but these but in general, you should have no cases for at least for a period of more than 10 years. And the final stage is then that leprosy is not normally present in the area or country anymore. Only some sporadic cases may occur, such as we have here, for example, in the Netherlands. We only have a few cases every year, and all those cases are foreign-born. So why leprosy models? I think, again, there is a lot of non-linear behavior of this infectious disease. There's always a backlog of cases because what we see in leprosy is you can only diagnose patients when they are asymptomatic, and there's always a huge backlog of cases. People don't go to the health facility immediately when they notice something because they are not aware that they have potentially leprosy. So there's a huge backlog of cases, also because of programmatic characteristics. Sometimes the program is just not good enough to detect cases. So what we see is there's a huge backlog of cases. We also know is that leprosy has a very long incubation time, usually on average around 5 years, but sometimes it can go up to more than 20 years, some individual cases. And again, what I said is that transmission dynamics are non-linear. Therefore, we use mathematical modeling. And for that, we at our department, we have developed this leprosy model that simulates the histories of life histories of individuals in a population structured by households, the transmission and natural history of infection, and leprosy control and intervention. And again, I'm not going to reiterate, this is the structure of such a model. And what we also explicitly model, so I zoom in on the natural history of infection, is the processes. So susceptible, they become asymptomatic, symptomatic, and then remain asymptomatic either until they receive treatment, or sometimes, especially for postbacillary leprosy, there's a chance they might self-heal and they come into the recovered phase. And we look at multibacillary leprosy, susceptible, they usually have a longer incubation time and they remain symptomatic until they receive treatment. What happens when they receive treatment? It really depends on at what stage you detect them. So traditionally, we know we can only diagnose cases when they are symptomatic. When they are symptomatic, for example, you can already detect them here. So they will enter the recovered state much earlier and therefore reduce the risk, therefore reduce the force of infection. Basically, you take one patient out of the group of patients that is contributing to the transmission. And if you do that earlier, the bigger the impact that is. Same here for recovered. In a hypothetical scenario, when we do have a diagnostic tool and can detect people that are in the asymptomatic stage, that would be even more perfect because then you can take them out of the pool of infectious individuals before they even get symptomatic when they are fully infectious. So is the line of think, the process of thinking when developing these models. How can we use these models and how can we think of different strategies to reduce the prevalence or the incidence of a certain disease? And again, I think what we're trying to do is always replicate the data. This is an example of Kiribati, an island country that we did a few years back. We try to, with our model, we try to replicate what we see in the real world, the patterns, the increases, the surveys that they did. The peaks are usually surveys, door-to-door surveys in the field, or sometimes other interventions. So let's focus on the first benefit of modeling. So what can model tell us? They can assess the performance of current practice. For example, what we often do in the field of leprosy is to predict, okay, the trend. This is the global number of new cases. What we can see here is we see a certain trend, and we just, based on the data that we have about this trend, in the most simplest form, we can just extrapolate, say like, okay, we know this is going on until 2019. It was pre-COVID, by the way, and after COVID, what can we? Oh, before COVID, this was a study that is unpublished because then COVID came in. But I think it's really informative to see what models can do. They can predict trends of the course of a disease. We can see like, okay, if we continue our same effort, considering there was no COVID dip, then we can expect that it still goes down, not really fast, but it still goes down. And in about like 20 years, we can see that we have gone from 200,000 cases to, I think, 160,000 cases. I think a more interesting way of using modeling is not only to predict the trends, but also to predict the estimated hidden cases. So what we see in leprosy, as I explained before, is the backlog of cases because of the health system or because of individuals that are not aware of having patches on their body. And what we can also use, what we can also calculate with these models is, okay, we can follow the observed trend that we have over time and make predictions of this trend. But at the same time, we can estimate with these models, okay, but what would be the number of undiagnosed cases at each point of time there? And we should actually follow here the undiagnosed symptomatic cases, because they are usually the cases that can be diagnosed. Well, the green line here is both asymptomatic and symptomatic. This is from a publication in the Lancet Infectious Diseases from 2016 that I've conducted with my colleagues. And what we can see is obviously that what we see what we observe is not always everything. There's always, especially when you look at the dotted line, you can at least see the same number of cases, especially if you follow the tail, and almost exactly the same number that you observe, that you detect, is also still there in the population. So this means that the number of cases might be twice as big as you have expected. So these models are really beneficial in informing policymakers, okay, what can we expect over time? And then to determine, okay, is this enough? Is this drop enough? And should we do additional preventive measures or not? And secondly, we can also look at the estimated hidden cases, like, okay, this is what we observe. How much potentially are we missing? And we see that we are now missing twice as much cases. Should we do additional preventive measures, yes or no? And this brings us to our next topic. When we think about the WHO elimination framework, we can also use modeling to assess the feasibility of achieving, in this case, we're now interesting interruption of transmission. And we have a case study. I have a case study here of the Maldives. It is unfortunately still unpublished, but it's submitted soon. I'm not going to reiterate this, but just as a reminder, we are focusing on going on to phase 2. So from phase 1, we're trying to reach interruption of transmission, and we are focusing on child cases. For some background information, when we think about the Maldives, they came from really far, had a lot of cases in the 70s, the 80s, and afterwards. They did good work in leprosy control. And in the last few years, the number of cases were on average less than 10 per year. And what we also notice is that in the last 5 years, or since 2017, no new child cases were there. So what we can do at the first place is we can do predictions of the course of the trend. So this is the case detection rate, is the number of new cases. You can see like, okay, if we continue like this, we always see some cases popping up still, but we see a good downward trend. What more interesting is with using models is that we can also calculate the probability of reaching 0 cases. And what we can do is, this is the probability of reaching 0 cases. And these are the years. And we can see, for example, that in 2020, the probability of reaching 0 cases is slightly below 30%. And with time, if they continue the current practice, it will increase to around 70%. Well, at the right-hand side, of course, more interesting because here we focus on child cases. And what we do see is that by 2020, using these data models, we can already predict that the probability of reaching 0 child cases is already quite high. It's more than 70%. And usually when it reaches 80%, 70 to 80%, it's a really good indication that this achievement has been reached. And so we can use mathematical modeling, data modeling to think in terms of probabilities and to say like, okay, does the Maldives indeed have each interruption of transmission? And then we can confirm that by now it's around 75% probability that really there are no child cases. And this is a really, really strong indication that they actually have reached this, the next phase in the WHO elimination framework. However, but in many cases, existing interventions are not enough to curb the trend that we see in real life. And this brings us to the second benefit of models, and that is to evaluate the impact of new interventions. When we talk about leprosy, there are a few options that we have: early diagnosis, post-exposure prophylaxis with a single dose of rifampicin, the development of diagnostics, or a vaccine. And also, we need to keep in mind that leprosy cases are unevenly distributed geographically. It's also important to understand what is needed in high endemic areas versus low endemic areas, because this may differ. So when we talk about early diagnosis, obviously there are many ways to do early diagnosis. This is an example of skin camps. Skin camps are camps organized to screen people that are attending skin camps on different diseases. One of them is, of course, leprosy. And because you organize these skin camps, it's a really low threshold. People can just come and can be screened, and you will usually find new leprosy cases if it's in an area where there are known leprosy cases. And what we can see here is what we see. What we do see is when we conduct those skin camps, we see a huge increase in the number of cases. And this is because you are detecting the backlog of that area. And afterwards, we see a huge decline because you have get rid of the backlog of cases at that stage. And then we see again it goes back a little bit up, and then we do another skin camp in that area, perhaps in another village, and then we again see an increase with a decrease over time. So this is a typically pattern what we see with early diagnosis. But what we also observe usually that in the long run, it doesn't seem to be going down that much more than the observed, the black line in this case. But what we can also use with models, as we said before, we can estimate the undiagnosed cases. And what we don't see is the prevalence of undiagnosed symptomatic cases, because having those skin camps really reduces the number of undiagnosed symptomatic cases in a population. So what we can use models for is also to inform policymakers, okay, early diagnosis on the surface might not reduce the number of cases that much compared to doing nothing, but under the water, what we don't see is that the prevalence of undiagnosed systematic cases are significantly coming down here. So this brings me to my next topic, is post-exposure prophylaxis with single dose of rifampicin. This has been tested in trials, and these trials showed that it reduces the risk of developing leprosy by almost 60%. And using the data from the trials, you can build this model. You can build a model, and we can make prediction. Okay, let's say we have this intervention, and then what would be the impact? And this is an example of the leprosy post-exposure prophylaxis program that we did in 7 countries, among Brazil, India, Indonesia was one of them, on the Madura Island. And we also, so programmatically, the intervention is as such, you go to context of index patients, and the context of index patients will be screened. If they have leprosy, they will be treated as a leprosy patient. If they don't have leprosy, they will be given a single dose of rifampicin as a protective prophylaxis among the contexts that don't have any signs of leprosy. And there is a chance, there's about 60%, that they won't develop leprosy because of this single dose of rifampicin. So it's not perfect, but it's something. And we do see that the number of contacts that were included was the highest in Indonesia, and therefore also the impact was also the biggest in Indonesia. What we can also learn from data modeling is there's always a backlog, because we are screening people, and because that's why at first the number of cases always increase. But we also learn from models is that it reduces not only the number of cases in a certain period, but also the time of reaching a certain level. So it's important that additional intervention will accelerate reduction, but also will lead to a bigger reduction. But again, there are marked differences between countries. It also It's determined by the historic and current control, the case finding effort, and the number of contacts examined. You can see that in Brazil, where there are only 11 countries, 11 contacts were willing to be screened, had a smaller impact than, for example, Indonesia. And we can also use models not only to compare countries, but also to compare different strategies. And this is an example from a high endemic island in Kiribati. What we can do is, for example, we have providing a single dose of rifampicin to own household contacts. But since it's an island country, what if we could screen and give single dose rifampicin to 80% of the island once or 3 times? What is then the effect? So you can compare different strategies with each other to inform policy making. Okay, what should we do? One-time blanket, household. What we can conclude, for example, here is that a blanket, in the short term, a blanket approach would have a bigger impact, but in the long term, not necessarily a bigger impact than, for example, only targeting household contact. So there's a trade-off here. Do you want to do both? Is your focus long term? Is the focus the short term? And again, we can also think of like, how do you want to roll out such a program gradually or instantly? So it really depends on how you're gonna implement such strategies. If you do it instantly, then you get rid of the backlog much faster, and then you can go down afterwards faster. But if you have a gradual implementation, well, the backlog here, there will still be a backlog, so you will find more cases for a longer period. And in the end, you can also use models to estimate global results in an ideal scenario. Here we did this publication, I think, from early 2020s, 2021, if I remember correctly. And what we did is we estimated the impact. So the year since we started SDR-PEP was the post-year prophylaxis and the change in new leprosy cases. So we can also inform policymakers by that if you do this consistently, then potentially it can reduce the number of cases by 90% in almost 22 years. So the final added benefit is determine specifications for tools and programs. And these are tools and programs that are still under development. And one of them is, for example, diagnostics. I'm part of the diagnostics working group for leprosy, and there we are always thinking about what are the criteria of these diagnostics, what is the target product profile of this diagnostics, and what are the desired or required attributes. And we can use modeling not only to assess its potential impact on the number of new cases in the population, but also to test, okay, what if you have different levels of sensitivity of such a test? To what extent does it matter if it's higher or lower? And it can really inform us that having, what the difference is from, for example, having a test sensitivity of 50% compared to 100%. One of the conclusions from this study is that even a diagnostic tool, because in leprosy we don't have any diagnostic field-friendly diagnostic tool at the moment. Any diagnostic tool, even with a sensitivity as low as 50%, already have a significant impact. So basically, it helps also as part of advocacy to say, like, we should keep investing, developing those diagnostic tools, because even though it's not the best, still can produce a significant impact. And the same we do have with the vaccine development. Here we have an example, a study also unpublished yet, will be published hopefully soon, about the vaccine development. What we can learn from this again is that the level of efficacy, which is denoted by the different colors, higher goes from only 10% efficacy to 80% efficacy. And we can also, based on this, determine that the efficacy of, in this case, it was a case study for the Lepvax vaccination, should at least have an efficacy of 60% to have added value in our tools for fighting against leprosy. And finally, what I also data modeling can be useful also to determine cost effectiveness, because we can make some forward predictions, and because of these forward predictions, we can also assess the cost for the next 10, 15, 20 years. This also might be helpful to inform programs. So how much would it cost to implement such a program? This is, for example, the study is part of the leprosy post-exposure prophylaxis in India. We could, based on also the forward projections we can make of the number of cases, we can also estimate how much such an intervention program will cost over time. And yeah, and also how much deaths might be averted over time because of this intervention. And we combine that, then these are cost effectiveness planes. You can then see if it's below the dotted line here, it's kind of it is cost effective. So most of these interventions are cost effective or borderline cost effective. So we're not going to go through the numbers, but I just wanted to show the use case of data modeling also to inform cost effectiveness studies, because as you can see, time horizon in years, you can look at the cost in 5 years, 10, 15, 20, 25 years. And this also might be helpful to inform, especially public health policies. So to conclude my talk here is, how can modeling inform policy and control? This is mainly the field I'm working in. So all the work that I'm doing is basically to inform policy and control at global level, at national level, and at subnational level. And there are 3 ways how modeling can contribute, for 3 main ways how it can contribute to this. First of all, assess the performance of current practice, and to help support the discussion of, do we need something else? Is this good enough? And then secondly, if the answer to that question is, well, we need to do something in addition to what we are doing now, then we can use these models to assess, okay, what should we do in this particular area? Is it early diagnosis? Is it single dose of rifampicin? Is it potentially, when we have a vaccine, the vaccine? And thirdly, it can also inform on the specifications for tools and programs that are still in development. And fourthly, I didn't mention it earlier, but in the end, it's all about advocacy. People need evidence to be convinced why we need to go or invest in certain programs or certain strategies. And these models, because they visualize the impact, they can quantify the impact, is really helpful to support policy making here, because we can quantify everything, and people we can quantify, we can visualize the impact, and even when we think about the cost effectiveness, even the return of investment, how much will it cost over time? This was my final slide. I want to open the floor for any questions, or I will give the word back to Yuri. Thank you for listening.
Okay. Thanks so much for the nice presentation and also clear information, and it's very nice. So we have a several questions. You can check in the chat, David, maybe, and you can see maybe 5 questions, and maybe you can answer the question.
Yeah.
First,
so there.
Refiludin.
Yeah, so maybe have your presentation. Yes, I think I will delete the unpublished slides, but the rest of the presentation will be circulated, right?
Yes, I have shared your presentation
Okay, yeah.
without unpublished data, so
Oh,
no
yes, I
worries.
see it now. Sorry.
Okay. Yes.
Oh, yeah, there.
Maybe you can answer the first question from MC
Yeah,
Rafidudin. Okay.
yeah. Yes, yes. I think yes. Leprosy is indeed a rare disease, relatively rare. Depends on which area you are referring to. At the country level, it seems rare, but again, at certain there are high endemic pockets within a country, and that is where we focus on. Uh, so again, so it's we need some data to be able to do some proper modeling. And yes, leprosy is rare at the country level, but if you zoom in certain areas, we do see like that especially the incidence rate can be very high, so it does not become rare anymore. I agree with you that the rarer the cases, um, the more difficult, more unreliable models will become, because if you have an area where only a few cases, like the Maldives, it's really, there's a lot of randomness there predicted by the model. The confidence intervals might be quite large, overlapping the zero at certain times. Is there a good minimum sample size for a good prediction model? I think you can do modeling even with low numbers. But you need to consider that that the predictions that you are making have a lot of uncertainty. So the higher the number, the more certain you will be about these models, and the lower the number, the less certain you would be. But it still might be very informative. So what I usually propose is, when we are focusing on areas with very low numbers, uh, there are tricks to, if you have good data of those numbers, then it would be possible. If you have limited data, uh, then it can be still informative, but I wouldn't use the numbers as such. It's more like the trend that you can visualize, but not necessarily can say like, okay, in 5 years we can expect one case, for example, or zero case. I hope this is answering your question.
Yes, I think so. You can continue with the second question.
Yeah, that is, in developing countries like Indonesia, we often face challenges translating data to real health policies. What would be the most practical strategy to bridge the gap between data modeling and actual policy implementation? I think, well, this is, um, uh, it's basically talking with the right people, stakeholders. So I think modeling is globally recognized as a very important tool to inform policies. I think you should also be honest, because modeling is not the truth. It's a simplification of reality, and it helps us to inform. So, but we don't use only modeling to inform policies, but it supports to the case that you are making for a certain policy. So that you should keep in mind. And yeah, so it's really difficult to answer this question, because I've experienced in many countries, and some countries are more open to modeling results than other countries. Also, depending on who is who is, for example, in charge of those health policies. Some are more familiar with modeling, others are not. So it really also depends. And I think the one way is just educating about um, the relevant stakeholders about the relevance of modeling results, and come with perhaps with examples from other countries where it does work to inform policies based on these models. Yeah, how can collaboration between data scientists and public health professionals be strengthened? Uh, I think you really need to work together. I think when developing these models, my experience is the only way is to strengthen collaboration is to do a real collaboration and not only informing each other. So when as a data scientist, you're only like showing results, but not involving either public health professionals or even people at or policymakers in the public health institutes. If you are not involving them from the start, then you always have a very difficult time to get to convincing them to be on board. So I think if you are really seeing a problem in your area for a certain disease, for example, leprosy or something else, I think the only way as a data scientist to strengthen collaboration is to start together. Is to start like we have this problem. We want to see what is needed to reduce this problem. What are your insights? What are the strategies you are thinking of? Keep be collaborative in that. Think together and then show results based on your discussions, on your collaboration. I think this often would help to strengthen collaboration. I think these were all the questions, right?
Yes, yes. Thank you very much. Maybe if anyone who want to talk directly to David, maybe you can raise hand and you can open your mic, so you can ask David about many things about the data modeling. Any other question, David? Do you still have any time to discuss with us? Because you
Yeah, no, I have 3 minutes. Sorry, I need to go to my
okay,
next.
yes.
Sorry, yeah.
Yeah. So you still have 3 minutes left. Okay.
Yeah.
Okay. Yeah, I still want. Okay. So there is no question, I think, because our chief of the club program only give thank you and also a good appreciation with your lecturing. Thank you so much. Okay.
Yes. Yeah. Thank you for inviting me. I hope this was very informative also to you all.
Yeah. Okay. So if there is no any question, so because David should do something else in his business, of course. So unfortunately, we cannot make any discussion longer. So we must finish this lecturing. And David, again, thanks very much for your valuable time, also for your a nice presentation and material. Maybe sometime you can visit me in Indonesia. Maybe you can visit to Surabaya. Yeah, you can visit your ancestor are there maybe.
Yes, I hope so. Yes.
Okay,
That's
okay. Thank you,
yes.
David.
Yeah.
Thank you
Thank you.
so much. Oh yeah.
Yes.
Before we go, maybe we can make any picture. So please everyone open the camera. So we make a picture, and maybe Mr. Nana or Mbak Vina, you can help me to make a picture. I'm sorry, I must because yeah. Oh, yeah, view. I will change the view. Yeah. Okay, we will make a picture. So please open your camera, and I will count in 1, 2, 3. Yes. Okay, and then we move to the next page. Yeah. Maybe Mbak Vina, you can help me to take a picture.
Yeah.
Okay. I will count 1, 2, 3. You can give a nice smile. It's done, Mbak Vina. Okay. And then we go to the last page. We make a picture. 1, 2, 3. Is it done, Mbak Vina?
Okay.
Okay, thank you so much, David.
Yes.
Again, thank you for your valuable time and for your nice presentation and also good expertise in your area. And I hope we can meet again. Maybe I can visit you in Rotterdam again.
Yes. Okay. Thank you
Okay,
so much.
thank you
Okay.
so much,
Bye-bye.
David. Yes,
Bye-bye.
bye bye. Okay. Uh, Bapak Ibu Saudara, terima kasih atas kehadirannya di, di sesi ini. Saya mohon maaf karena David memang memberikan pesan hanya sampai pada 1,5 jam dan biasa orang Belanda begitu tepat 1,5 jam dia langsung lari ke bagian yang lain. Tapi mudah-mudahan itu semua bisa menjawab apa yang menjadi presentasi dari David. Begitu Bapak Ibu Saudara, mungkin ada yang ingin tanggapi? Kalau tidak, saya cukupkan sampai di sini. Saya mohon maaf selaku moderator kalau ada hal-hal yang mungkin belum berkenan di bagi saudara. Dan karena David sudah tidak ada, saya pakai bahasa Indonesia saja. Karena kita ber-90, hanya dia yang pakai bahasa Inggris. Saya pakai bahasa Indonesia saja supaya lebih jelas. Saya kira begitu. Terima kasih atas partisipasi rekan-rekan semua, para mahasiswa DKM, dan para kolega yang telah mengikuti acara ini. Mudah-mudahan ini menjadi salah satu bagian untuk peningkatan mengeksplorasi tentang keilmuan public health, terutama terkait dengan data modeling dan aplikasi statistik. Kalau Bapak Ibu semua mungkin pengen lanjut berkolaborasi atau berkorespondensi dengan David, saya bisa bantu menyediakan alamat email. Saya kira begitu, atas perhatiannya saya ucapkan terima kasih, kurang lebihnya saya mohon maaf. Saya akhiri sampai di sini. Wassalamualaikum warahmatullahi wabarakatuh. Matur nuwun semuanya. Saya izin live dan selamat melanjutkan aktivitas berikutnya. Sugeng sonten, selamat sore dan bye-bye.